All 9 counties are HIPSA-Ds, health provider shortage areas for dental in southeast Kansas. The average age for a rural dentist in Kansas is 55, so that means in 10 years we're in serious trouble. Although, when surveyed, they say they're not ever going to retire. A lot of that is patient abandonment. It really is. People in rural communities, as you've probably talked to these guys, they don't want to quit because there's nowhere else for their folks to go. And that's been a lot of the discussion that we've had with some dentists who've come to work for us, who we assured them that their patients could still come and see them. They could work. The average age for a safety net dentist is 43, and the average age for our dentist is 38, and that's just because we have one outlier who's like, mostly we have young kids who work for us, and it's great. Very committed to what we do. We started in 2003 with a closet. This was 144 square feet. That's Dr. Gary Brown. He and one other person volunteered. That's all we had. And we developed an 800 patient waiting list very quickly. And so that was our closet. And we now have, we had 1 chair then, now we have, I think, 36 in different locations. The next year we had a thing called the Mission of Mercy. If you don't know about those or your state doesn't have them, really look into those. It's a 1-day dental or a 2-day dental clinic. About 2,000 people get free dental care. That happened in Pittsburgh. It became a catalyst for us doing what we do. We opened our main dental center in August 2005. It's got 15 chairs, 5,500 square feet, and we started hiring dentists. And then this is our dental expansion. And the reason why we could do this is because we have a lot of private foundations in Kansas, a lot of which who funded this, all of which who funded this conference, who have been incredibly generous to us and given us incredible amounts of money to do what we do. So we have 2 clinics in Pittsburgh. That big one that I showed you, our main medical clinic has dental within it integrated. In Columbus in April of 08, Iola December of 08, Pittsburgh Children's Clinic in 09, and this year Baxter Springs in 2010. That's a map, and it's not going to mean a lot to you, so we'll keep going. Our outreach program is incredibly innovative and aggressive. We screen 20,000 kids in southeast Kansas every year for oral health problems. Then in 2 counties, we actually go on-site, take a dentist on-site and do restorative care. The poorest school district in Kansas is in a place called Galena. It's in far southeast Kansas. It was heavy lead and zinc mining. The other thing that's different about southeast Kansas is it's very different than, it's not rolling hills and all that. It's coal mining, it's lead and zinc mining, it's a whole different kind of thing. It's a poorest school district in Kansas. The assessed valuation for the entire district is $3 million. So this hotel is worth more than that entire district. We have completely eliminated oral health disparities in Galena. We took care of 155 of their 500 students, completely completed their treatment plans, finished them. The poorest school district in Kansas, which tells me we can do it all over the country if we just think about it, we just work at it. So from there, we've expanded to almost every school in 2 counties. We take care of all the Head Start kids in southeast Kansas. There's about 900 of them. We go to every WIC clinic, and we go to long-term care facilities. And I'll talk real briefly in a minute about how we're able to do that. We have some very progressive legislation in Kansas that allows us to do that. This is a portion of our dental staff. There's 33 of them now from that closet with 1 volunteer. We now have 33 full-time staff, including 6 dentists and 9 dental hygienists. And I can't tell you how proud I am of these guys. Why we do it? These are some of the reasons why we do it. This is a kid in Riverton who was living in a car with his dad, had no toothbrush. And we fixed his mouth, and we got kids now. We have janitors telling us in schools that they see like the foamy bubble stuff on the sinks from kids brushing their teeth. And we got incredible coverage from Brian Thompson, who's here today, about that. But that's been a wonderful program. In that school, in Kansas, about 30% of our kids have sealants. In that school, the poorest school, 52%. We have a thing called Bridges to Work, which is a program that allows us to take care of working-aged women and help them get back into the workforce. This is a before and this is an after. Is she not beautiful? And she's got a job, because that's what people told us when they came in. They said, I can't get a job. I can get a job, but I can't smile and I can't get a raise. This is Michael. He's from Coffeyville. Coffeyville's an incredibly poor city right on the border with Oklahoma. And he came to us. His school counselor drove him an hour and a half because he couldn't chew food. They were feeding him oatmeal. His grandmother was disabled. He had, an abscess that could have killed him. And we know about DeMonte Driver, and we know that story. This is the boy that didn't die. This is the boy they brought to us. We took care of him, got him out of pain, got him all fixed up. This is him smiling not long after we took care of him. And when we went back to do the oral health screening, incredibly great story. And this is a great story. He walked in, he grabbed the hand of our hygienist and our dental assistant who do the screenings, turned to his classmates and said, "These are my friends and they're going to help you." You know, what's that? So that's Michael. Models of care that I want to tell you about real quick, how this happens. Clearly, community health centers are going to be a critical aspect of how we provide care in underserved areas, particularly rural areas. There are rural areas now where the only place you can go is a community health center. There's nothing else because there's this whole infrastructure behind them. National Health Service Corps loan repayment, scholars, all kinds of those programs that help bring resources. But clearly the establishment of bricks and mortar, but the school outreach programs are going to be critical too, doing things with lower overhead costs and getting out. The extended care permit is a thing in Kansas that was passed, I believe, in 2005. What it does is it allows hygienists to provide services in certain settings without a dentist on site. So schools, Head Starts, health departments, community health centers, that's how we do all of what we do. So they're kind of sentinels for us. They go out, they screen, they can do cleanings, they can do sealants, they can do fluoride varnish. The reason why this works well in Kansas is because those are billable services. So if I can send a hygienist who doesn't cost nearly as much as a dentist, and she can go to a school and take care of 12 kids, I'm going to get paid way more than it cost me to send her. So there's an economic incentive for health centers, at least in Kansas. It's a very progressive state in that way. But it's a good program in which we put people in touch with the kids who need them most, and we find a way to pay for it. The Dental Hub program is something we've done in Kansas, where all of our private foundations and the state of Kansas work together to fund something, and it's incredible to watch because they all have their own processes and their own politics. But I think $9 or $10 or $11 million went into this program in about 3 years, and what it did is we made it a competitive process for clinics, community health centers essentially, to establish themselves as hubs, and then spoke off as satellites and extended care permit hygienists, because you believe those rural hubs are places that are growing. Towns of 20 and 30,000 are getting a little bit bigger in Kansas, where the smaller towns are going away. So this is a way to build infrastructure, multiple dentists, so if somebody retires or leaves, your whole system doesn't come crashing down. That's something that we've done, and there's something kind of similar in Wisconsin, although it was done more with public money and also done in a more planned way than what we did. The other thing to watch is the dental therapist model that was mentioned. There's a pilot grant from Kellogg in Kansas and I think 4 other states to look at this model, where it's essentially somebody from the community who is not necessarily a hygienist, but who can do lots of stuff, including restorative work and simple extractions. I mean, it's dental care. It could be a hygienist, it could not be a hygienist, but that's the model that's being looked at. And I really look into that because our workforce problem is huge. With medical care, if we had everybody covered tomorrow, we'd be 40,000 doctors short, medical doctors short. I don't know how many dentists we are short, a couple 100,000. So what we have to do is look at alternative ways, because we can't train enough. We can't keep enough. We don't have a dental school in Kansas. We trade 22 slots at UMKC, Missouri Kansas City Dental School, for 491 architecture spaces. So it's 22 for 491. That's our trade. And apparently it's expensive to have a dental school. And you guys know in the 80s we have an oversupply, so the whole dental world said, wait a minute, we're not going to make enough money, so we're going to start closing dental schools. And now we're seeing the problems of them controlling the market is what they did. And obviously when you don't have enough dentists, you don't have enough dentists to take care of low-income folks. Although the opportunities in clinics are pretty good because you don't manage, you don't own, you just show up and be a dentist. And a lot of the kids coming out, if you guys haven't talked to them, really like that idea. They like just showing up and being a dentist. We pay competitively, we have good benefits. It's especially for people who are mission motivated. This is the kind of place.